Hello, everyone, and welcome. Good morning, good afternoon, good evening from wherever you are joining. My name is Dr. Volker Humbert. I'm Senior Director Medical Strategy at CytoSorbents. I'm a trained anesthetist and intensivist by background. And it's my pleasure to present you today the latest developments update. It will take roughly 35-40 minutes in hemoadsorption in critical care in whom, when, and how. The rough agenda looks as follows. So I would briefly go through the rationale of using hemoadsorption in the setting of hyperinflammatory conditions, then present the product itself, so the CytoSorb adsorber, share with you some recent clinical data and also the lessons we learned from them and the current understanding of the best practice in regard to patient selection, timing and dosing, provide an outlook on what to expect in the coming weeks and months, and end up with a summary. And after that, we of course have time to discuss one or the other open question. And with this, I would also like to encourage you, if you have any question, to enter them in the Q&A section of the Zoom toolbar at the bottom of your screen. So don't try to enter it in the chat. Please use the Q&A section therefore, and I'm supported by my medical colleague, Dr. Teresa Klaus, also a trained anesthetist and intensivist by background. So she will answer one or the other question directly in a written manner, or we discuss it after my presentation then in more detail. So I'm looking forward to receiving questions. And now let's start with the presentation. Let's start with the rationale. The sepsis 3 definition, I think, very nicely puts the dysregulated host response to infection in the center of the problem with sepsis. So it's not necessarily the infection itself, it's rather the reaction, the response of the organism to it. And even if not every single detail of this dysregulated immune response is understood in full detail, the principal characteristics, I think, are quite well known. There's a hyperinflammatory response, which can lead to early death due to an overwhelming inflammation. But as a kind of compensatory mechanism, there's also immunosuppression as a response. And if this is persistent, it can lead to late death due to this persistent immunosuppression and recurrent infections. So let us call the y-axis slightly different. Let us speak about pro-inflammatory responses and anti-inflammatory responses. And I think this makes clear that we shouldn't speak about good or bad cytokines, or that we should only see the anti-inflammatory as a good response and the pro-inflammatory as a negative, bad response. I think every response has its meaning, has its place in our organism. It's more a question about being physiologic, so rather helpful, or being dysregulated, pathophysiologic, and so rather harmful. The clinical picture of this cytokine storm in aseptic or vasoplegic shock is, I think, well known. You know about the vasoplegia problems, you know about the capillary leakage of those patients, and you know about the disturbances in microcirculation. So reducing those elevated levels of various inflammatory mediator cytokines from the blood can have consequences, positive consequences for this hemodynamic stability. And this is our hypothesis for the role of CytoSorb. Admittedly, not every single aspect is fully proven, but more and more clinical data point towards this hypothesis. So the idea is that the reduction, as I said, of cytokines and other inflammatory mediators, and here we also speak about the important trigger substances, the damage-associated molecular patterns, the pathogen-associated molecular patterns. This reduction leads, on the one hand, to less vasodilation, so less hypotension. On the other hand, it leads to less capillary leakage and so less edema. And both of this is contributing to a better macrocirculation and also a better microcirculation, which then is the base for better organ functions. Let us have a look at the product itself, the CytoSorb adsorber. When you speak about CytoSorb, we speak about a cartridge which is filled with highly biocompatible, quite little porous polymer beads that have also numerous pores on the surface. And these beads can remove various substances from the whole blood. The removal, importantly, is based on the process of adsorption. So CytoSorb is no filter, there is no membrane. CytoSorb is an adsorber. Adsorption is attachment onto a surface. And this surface, the relevant surface for adsorption, is located in the inner of the beads. Therefore, a substance has to be small enough to enter through the pores on the surface to get to this adsorption surface, which why a size-selective removal is given, and the threshold is at around 60 kilodalton. Additionally, the substances have to be rather hydrophobic in nature, so exactly the opposite of what is normally removed by renal replacement therapies. The hydrophobicity is needed to develop the adsorption interactions. Another important feature is the so-called concentration dependency, which is a kind of autoregulation providing a high removal efficiency only at highly elevated concentrations. The more and more physiologic, the more and more normal the concentration becomes, the lower the removal efficiency by CytoSorb, up to the point where not really any removal is happening anymore. All this is first of all contributing to a quite favorable safety profile. The concentration dependency is supporting restoration of a physiological immune response by targeting mainly the highly elevated, dysregulated toxic levels of the inflammatory mediators and preventing a complete removal of a physiologic mediator, which would also rather be harmful. The size selectivity is excluding larger substances, which are too large to enter through the pores on the surface, and studies and investigations have shown that there isn't any significant removal of albumin, no relevant removal of coagulation factors or immunoglobulins to be afraid of when using CytoSorb. Last but not least, the high biocompatibility of the materials involved is providing not any activation of the coagulation or complement system, and as studies have shown, the loss of platelets directly due to the adsorber is also only minor. All this is further supported from experiences from the fields. We assumed that to date, we have more than 179,000 treatments being performed in a wide range of critically ill conditions and patients. You have various target substances when using CytoSorb, and depending on your target substance, you come to different fields of use. So when you primarily target cytokine removal, you can use CytoSorb in the field of septic or vasoplegic shock conditions, in severe acute pancreatitis. I'll show you a nice publication towards the end of my talk, or in the field of cardiac surgery with either an intraoperative approach or a postoperative approach. Maybe some of you might have joined yesterday when my colleague Professor Wendt has presented this in a other webinar. Also in cardiac surgery, you have the antithrombotic removal as an approach to reduce or prevent bleeding complications in emergency cardiac surgery, and targeting bilirubin or myoglobin is providing the rationale of using CytoSorb in the setting of liver failure or rhabdomyolysis. There's a lot to say about also these other promising indications. However, I would like to focus mainly on the field of septic vasoplegic shock. You see once more here the illustration of an infection via the pumps leading to a dysregulated immune response, a septic shock, which is further deteriorating into a multi-organ dysfunction syndrome. Importantly, a very similar response can occur also from sterile triggers. So severe burn, severe trauma, major surgery, or shock states can result in a very similar dysregulated immune response with more or less the same clinical picture of multi-organ dysfunction syndrome. And the use of CytoSorb is meant to address specifically this cytokine storm, specifically this dysregulated immune response, as this is not directly targeted by all the other standard therapeutic measures. But of course, the other standard therapeutic measures are still very much needed and cannot and shouldn't be replaced in any way by CytoSorb. CytoSorb is to be understood as an adjunctive therapy. The major effect of CytoSorb is hemodynamic stabilization. This is shown in a variety of publications and nicely summarized in this review, where also a potential vicious circle is illustrated that not only the cytokine storm can lead to vasoplegic shock, but also the vasoplegic shock can by itself, by ischemia reperfusion syndromes, also trigger further cytokine production. And the review summarizes the available data, and these data indicate quite an important contribution of hemoadsorption in achieving rapid stabilization, especially in those patients with refractory vasoplegic shock. So especially in those patients who are not responding properly to standard measures alone. But let's have a look at the clinical data, at the development of the course and some concern is that there isn't any RCT showing the evidence in septic shock yet, which is of course right, that there isn't any RCT yet. There was a very early RCT being performed even prior to the CE certificate. The major idea was to show safety and feasibility, which was achieved. To fill the gap, we started last year, the so-called process RCT. I will have some words on this in some minutes. But let's have a look at the other publications, which are, despite not being randomized controlled trials, still providing quite helpful and very important relevant clinical data. They all show safety and feasibility. They support the hemodynamic stabilization and reduction of vasopressors, as I just said, as the major clinical effect of CytoSorb therapy in this setting. And they provide initial signals of an improved survival. Here's a relatively recent publication from Innsbruck. It's a retrospective single-center study, and they looked at 42 patients. They had septic shock. They received CRRT treatment, and based on the discretion of the treating physician, they were also treated with CytoSorb. And these 42 were compared to another 42, which were matched out of nearly 3,000 control patients to be a very good fit to those 42 CytoSorb patients. Those patients also had septic shock. They had, of course, also CRRT, but they didn't receive CytoSorb. And when you now look at the course of the hemodynamic stabilization or at the course of the norepinephrine doses, you see quite a nice ongoing reduction after initiation of CytoSorb therapy, which you don't see in the control patients. Control patients had a bit of a lower level, so it might not be that impressive like this. So let me use a bit of a trick and shift the control level up to the same level where the CytoSorb patients had their starting point. And now you can see by far better the difference in vasopressor reduction, in hemodynamic stabilization with or without CytoSorb therapy. Additionally, you see a nice pattern of shock reversal, so increasing doses of norepinephrine prior to the start of CytoSorb and decreasing doses after initiation, which is a pattern we also know from earlier studies like the Friesike study, who specifically looked at refractory septic shock patients and could make the same observations. As I said, the study is also providing signals towards an improved survival. Obviously, we can't call it evidence. It's just signals. It wasn't powered for mortality, but it's very nice numbers anyway. It's a significant difference in 28-day mortality as well as in hospital mortality. There are further data on mortality coming from a very similar approach from the Netherlands, from the group of Can Inche. Here again, patients with septic shock were treated with CRRT and CytoSorb in comparison to patients that were only treated with CRRT, next to standard measures, of course. And again, the patients tried to be compared to each other, and that's why a method had to be used to adjust for differences in the baseline characteristics. Here, the inverse probability of treatment weights method was used. And after having applied this model, you could again show a significantly reduced mortality in the CytoSorb treated patients in comparison to the CRT group. And the authors did the effort to follow up those patient cohort for quite a long while, for up to a year. And you can now see that this difference is still remaining, existing after nearly a year or even longer. So it wasn't only an effect for 28 days, it was a longer lasting effect after having applied these models. Other interesting findings from these two publications I just mentioned are as follows. It's about lactate levels as a potential predictor for mortality or for outcome. So the Netherlands group found that lactate levels above 6 are an important determinant of outcome. And in a similar way, the Innsbruck group found that lactate levels higher than 7.5 prior to CytoSorb mounting can predict mortality within the CytoSorb group. So this gives us indications that one shouldn't wait that long until those high levels are reached, because maybe potentially then already irreversible damages have occurred and you might no longer really change the clinical outcome in any way. Admittedly, there are not only positive data in the field, so I want to be frank with you, and there are also studies there which do not support the findings I just showed you before. So this is a study from Zurich. It's again retrospective investigator-initiated approach, similar, again, 48 patients were this 48 controls. The CytoSorb patients, again, had renal replacement therapy and had a septic shock. However, they were really sick. They were extremely ill with high sulfur score levels, high norepinephrine doses, and also quite high lactate levels. So quite close to the 6 to 7 I just presented to you as potential predictors of a bad outcome. The historical control groups were less sick before the matching. However, also here, I think, I'm not a statistician, but I think a proper sound method for making the two groups more comparable was used. So the conclusion here was that the cytokine adsorption was not associated with any reduction in IL-6, also not any reduction in vasopressor requirements in comparison to a control group, and it led to an even increased hazard of death. So when we take this, we can of course speculate whether in this setting, CytoSorb was started too late, given those really high numbers of the sulfur score and the high lactate levels. But when we take this, it's only speculative, I can't prove it. As it is, then we have a pattern we also see for other therapies. We have a study reporting worse outcome in regard to mortality. We have studies reporting positive outcome in regard to mortality. Hyman and al. recently did the effort to look at the meta-analysis of randomized controlled data in regard to mortality. And as the authors said by themselves, this is really on a very low level of certainty. And I think it has to be interpreted with a lot of caution, because this is a mix of various indications, so which probably are not really comparable to each other. Some indications were not even hyperinflammatory, or the levels of inflammatory markers were rather low. Certain limitations or baseline differences in one or the other study, despite randomization, weren't properly adjusted to our understanding. And probably most important, none of these studies were powered for mortality. So one can generally question, is it the way to go to always look at mortality? When we look at other approaches, generally, this is a nice review looking at any evidence for pharmacologic interventions to reduce mortality in critically ill patients, and they didn't find any. There wasn't any conclusive evidence. So there's more and more the question whether mortality as an endpoint in an RCT is not only a tricky approach, but also, is it a reasonable approach? Because when you look at this nice illustration, you see that those critically ill patients have many reasons of dying. And some of this mortality risk is syndrome independent. So it's even more unlikely that one single therapy can address all this, especially those risks which are not even dependent or associated with the syndrome. So in this regard, I think we should rather go for more proximal outcomes like organ dysfunction and not really assess the therapies only whether or not they reduce mortality. Here we sometimes might do a wrong or false assessment. And as another take-home message, I would say, importantly, and this is again for every therapy, to be successful, you have to do it in the right patients at the right time and with the right dose. So patient selection, timing and dosing is crucial, and it's a decisive therapeutic aspect, not only for CytoSorb therapy. So we try to look at those studies, some of them I presented to you earlier, and assess their approach in regard to patient selection, timing, and dosing. And admittedly, this is not trivial, this is tricky, and there's no black and white, and it can be discussed. And I don't want to go to every single detail. I just want to show you, after assessing this and rating this, a bit like a traffic light system into green, yellow, and red, you can see that a certain pattern. And the more green you have for the selection, timing, dosing criteria, the more likely you have green for the outcome. And the more red and yellow you have, the more yellow and red you have for the outcome parameters. This is, please, not taken as any criticism to the authors. Sometimes the knowledge we have now was by no way given at the time the study was conducted. For example, the Schädler study was conducted 12, 14 years ago. So the understanding back then was by far not the same as we have now. It's just trying to illustrate that proper patient selection, timing, dosing might not only be the prerequisite for therapeutic success, but might also explain why one or the other study has not led to favorable results. So our current understanding of the approach is as follows. CytoSorbent septic shock should be used in refractory septic vasoplegic shock patients that do not adequately respond to standard therapy and have high or even increasing levels of vasopressors. Biomarkers to further support hyperinflammation can be used IL-6 with a threshold around 500. Some studies used even 1,000, PCT of 3, and ferritin above 1,000. Timing is very important. We know this from earlier publications. We know this from pathophysiology. And so one shouldn't use CytoSorb when irreversible damage is already occurred. Lactate might be, as I just presented, a potential predictor or signal to show this irreversible damage. So one shouldn't wait until those high levels are there. In principle, we say CytoSorb should be initiated within the first 24 hours after diagnosis and start of the therapy. 12 hours might be even better. I'll show you some data in this regard soon. And it's also important how to continue. And maybe this aspect was ignored to some extent, or maybe at least not focused that much by myself, by the company. We know now even more that it's not only about the continuation in principle. So of course, the therapy should be continued until adequate hemodynamic stabilization has been achieved, but it's also about the intensity. And maybe, especially if instability should persist, you should make your therapy even more intense and change the first adsorber, not only after 24 hours, but already after 12 hours to increase the intensity and to hit hard and early, as we also know from other approaches in these really critically ill patients. So on average, this might result that you use 3 to 4 adsorbers per patient. Klaus Kugelmann and others have invented a score to support initiation of CytoSorb therapy. That's the so-called CytoScore. And this is, as you can see here, very much focusing on hemodynamics. So it's assessing lactate levels, it's assessing norepinephrine levels, it's assessing the presence of a second catecholamine or hydrocortisone, and it's assessing the volume load or the amount of volume therapy. It's interestingly not only assessing the absolute status, but also the changes over time. So you also have to assess what did lactate do in the preceding 6 hours when you did your standard therapy? What did the norepinephrine doses do in these preceding 6 hours? And then you come to a point and a final score. And this score, of course, still, to be frank, needs proper validation. However, together with some authors from Austria and Switzerland, Klaus Kugelmann, did a first evaluation of this scoring system in more than 500 septic shock patients. Nearly 200 of them had received CytoSorb therapy in a variety of septic problems, pneumonia, abdominal sepsis, and urosepsis as the major ones. And multivariate logistic regression analysis showed that every hour of therapy delay is increasing the odds of mortality at day 56 by 1.5%. So it's further supporting the importance of early start, of a timely start of CytoSorb therapy. Of course, the impact of an hour delay is not as dramatic as an hour delay in antibiotic therapy. Don't get me wrong here, but it's anyhow supporting that really also here time matters and every hour counts. So if you take the right patients and use CytoSorb timely, then you really might make a difference. And this was shown in this paper as well, because Klaus Kugelmann selected those patients that had the highest DSS, or the CytoScore points of more than 8 points. So this means those patients were really refractory to standard therapy. They didn't respond in any way. And if those patients were treated within the first 12 hours, then you could show nice signals towards an improved outcome. It was low patient numbers, and again, it was not prospective, but it was very nice numbers. You see here a 92% mortality in the control group patients and only 50% mortality around in the CytoSorb treated ones. So this tendency was also given in the range of 6 to 8 points. However, there it was not significant. So what we learned from now, the diagnosis of septic shock is of course always first, and then you should immediately start your standard therapy. After 6 hours, ideally, evaluate your CytoScore. And if you're above 6 to 8 points, then you should start with CytoSorb, ideally within the next 6 hours. We will learn more about using CytoSorb in septic shock from our process RCT. That's really one of our major projects which are currently running. This is a prospective randomized controlled trial. The aim is to finally recruit 160 patients. The primary endpoint is not mortality, as I tried to explain you earlier. It's organ dysfunction, or here the percentage change in noradrenaline at 24 hours. So there are approximately 20 to 25 study sites in Germany, and PI is Professor Kluge from Hamburg University Hospital Eppendorf. Another very interesting project is the so-called Cosmos Registry. Some of you may know that there was a registry from Jena run by Professor Brunkos, which had to be stopped. Now, this is the successor, and this is an ongoing approach. It's data collection similar to the Jena registry during routine clinical care. So the clinical data only derived from standard clinical care. There's no protocol, but there's a prospective approach, and the enrollment is planned to include 3,000 patients in total within 10 years. The PI is Dr. Ricard Ferrer, a well-known expert in blood purification from Hospital in Barcelona, Spain. However, until these results are there, I think we already have a certain understanding of how to use CytoSorb in the best possible manner in septic shock. I already presented to you the criteria. We already transferred this into a flow chart, which might be more appealing. It's of course a bit of a simplification, but anyhow, hopefully a guidance to treat your decision-making towards CytoSorb even better. And it shows that after starting your standard therapy, the crucial question is, has the patient improved from a hemodynamic point of view? If yes, then continue with your standard of care, never change your winning team. If not, you have various potential criteria to come to the decision with CytoSorb. High elevated levels of norepinephrine, lactate levels, inflammatory markers, or the CytoScore, which is even more dynamic and assessing also the response in points with the standard therapy by itself. And if you then come to the decision to start CytoSorb, you should do it immediately or as early as possible within the coming 6 hours. And here we display a very intense treatment regime, changing the first 2 adsorber after already 12 hours, and then continuing the therapy until shock reversal. Admittedly, it's an individual decision, so depending on the individual course, you might also allow yourself a certain longer interval for each adsorber, or you might allow yourself to stop the whole therapy after already the second adsorber and not necessarily have to go through 3-4 adsorbers every time, but it remains an individual decision. And in some patient, you can really make a difference with a more intense approach. And that's why our other decision support card, which is more or less saying the same, but just in a different way of illustrating, is saying you should change this if instability persists. And this might also explain some differences in the Innsbruck study and the Zurich study. So the Innsbruck study, if you recollect the illustration I showed you beforehand, had an ongoing continuous stabilization. So here it was, of course, fine to not change the adsorber any earlier. In the Zurich study, there wasn't any progress here. It was unfortunately an ongoing, a persistent instability. So maybe 12 hours would have been better here. Again, it's speculative. I cannot prove it in any way, but it's something we learned from other reports that in those cases, an earlier change of the adsorber really seems advisable. And we have other results like this coming from Germany, from the Herford group, showing that high dose is associated with a better outcome. Here, the authors very nicely tried to calculate the dose, calling it the amount of blood purified, by taking the duration of the CytoSorb adsorber and multiplying it with the blood flow and taking it into relation of the actual or to the actual body weight. And they analyzed quite a variety of patients that had more or less the same level of clinical severity, so more or less the same Apache 2 scores. But those that were treated with the highest dose, or with the highest amount of blood purified, had by far the best outcome. So this is supporting increased doses, and the dosing regime with this 12, 12, 24, 24 is also supported by our very nice US data. As some of you might know, the CytoSorb therapy is not approved in the US, it's not FDA approved, but since April 2020, it is allowed to be used in COVID patients under the so-called FDA emergency use authorization. And here the FDA or a specific fixed dosing regime was required. So it said to change the first 2 adsorbers after 12 hours and then 2 further adsorbers, 24 hours each, and then do a re-evaluation. And under this setting, 52 patients from 5 US centers were analyzed. They were captured in our CTC registry, and this publication was published in the course of this year. And the mortality is really nice. The 90-day survival in these critically ill patients that also received ECMO therapy is 73%, which is by far better in comparison to the ELSO COVID-19 ECMO registry numbers. We will learn more about these patients, namely the full cohort, which is including 100 patients, at the upcoming ESICM Congress. There will be an abstract presented that shows unaltered high survival rates and shows quite some signals towards early initiation of CytoSorb being a key feature and may even support shortening organ support requirements. At the ESICM, there will also be an abstract for a rat model of sepsis-induced acute kidney injury. And this model showed that extracorporeal circulation itself may cause the systemic and renal impairment. However, hemoadsorption can restore not only oxygen availability, but also reduce renal tubular damage and inflammation and sepsis. And a septic shock model in sheep showed that CytoSorb reduced the need for intravenous fluid administration without increasing the vasopressor requirements. One publication I would like to show, which is already there a while ago, on CytoSorb in severe pancreatitis coming from Munich, Rechts der Isar Technical University of Munich. They assessed or included in a prospective manner 16 patients with severe acute pancreatitis. So they find that the onset of pain had to happen within the last 7 days, the Apache 2 score above 10, and they had to have one marker of a poor prognosis. They used 2 CytoSorb, it was a bit of a pilot approach, and compared this to 32 matched control patients. The primary endpoint was either an increase in cardiac index or a reduction in the vasopressor dependency index. And this primary endpoint was reached significantly more often in the control group than in the intervention group than in the control group. And the IL-6 levels also showed a nice reduction in the CytoSorb treated patients. And also the SOFA score assessment was improved in the CytoSorb treated patients in comparison to the historical control groups. So summarizing this, there's much more than just sepsis, and there's the severe acute pancreatitis, there's the field of cardiac surgery, and there's liver failure, rhabdomyolysis, as I said beforehand. Some final words on other approaches which are there on the market. They might have the same target, they might have the same rationale, they might have the same, let's say, clinical criteria. However, we should make sure that adsorber is not necessarily adsorber. They come with different technologies, different materials. As Klaus Krenn nicely pointed out, in regard to clinical results, particularly safety relevant aspects, you can't transfer results between the products due to the technically different procedures. So every adsorber has to get their data together by themselves. And I think we're not there where we want to, but we are on a good way, I dare to say. We already also have a recent comparison between the Teflon HA380 and the CytoSorb 300. And when you look at the curves, the green one is the HA380, the red one is the CytoSorb. You see quite a difference that the CytoSorb removed cytokines much faster and more efficient. So both removed cytokines, but the measured dynamics and efficiency really seems to be in favor of the CytoSorb device, and therefore it may be the preferred device in septic shock states when it's about rapid cytokine clearance. And it's always about being rapid there because it's really critically ill conditions. Other recent publications are there in regard to safety. I often heard concern, and this is fair enough, is unwanted drug removal. Of course, every extracorporeal therapy can remove drugs in an unwanted manner. So we investigated this, and of course we will continue to investigate this. This is a nice article from Antoine Schneider looking at 17 anti-infective drugs in a pig model and applying various pharmacokinetic models. The conclusion reads nicely that it appears to have limited effect on the pharmacokinetics of the majority of the drugs tested. So it's of course not the guarantee that there will never be any intervention or impact, so to say, but for the majority of the drugs, luckily, it doesn't seem to be a major impact. This is also further supported by this publication from Munich that showed that there were no clinically relevant removal of meropenem by CytoSorb in those patients with septic shock. However, a substance where we know that quite some elimination is possible is vancomycin. And again, the group from Munich looked at this very detailed, and they could show that with CytoSorb, you will have an impact on vancomycin levels, and you have a high risk of being subtherapeutic if you don't do anything. They applied further models to come up with a compensatory dose, and therefore they suggest to use an additional dose of 500 milligram vancomycin over 2 hours to avoid this. So the good thing with this removal is once you know how to compensate, you have, of course, an approach to compensate and to get back to normal levels. An interesting finding, however, of the study is also, and this shouldn't distract from the impact of CytoSorb, but it's anyhow interesting that nearly 50% of the vancomycin concentrations without CytoSorb were also in the subtherapeutic range. And I think this just highlights even more that therapeutic drug monitoring is highly needed. Those critically ill patients have many reasons for a completely different pharmacokinetic. It's not only about CytoSorb. There might be impacts of renal replacement therapy. There might be other impacts. So it's really advisable to have, as good as possible, a closer look at this. And with this, I'm at the end of my talk. And this is the final table. It's the growing body of our clinical data in regard to CytoSorb therapy. We have more and more treatments, more and more documented treatments in patients, more and more publications. The registry, as I said, will sooner or later be really replaced by the Cosmos registry. So these are the numbers still from Jena. And the clinical trials, we need them, are also progressing. And I showed you we have an RCT in the field of septic shock, and other RCTs are on their way as well. And with this, I thank you once more for your attention and for your interest, and I'm really looking forward to your question. Thank you. How we know when switch the cartridge, which parameter take in count? So this is a question, a very relevant question from Gabriel Preda. Thank you very much for this question. Ideally, we would have a saturation indicator, which is not there yet. So we have to base it on the clinical course. And as I tried to say, if you have an ongoing instability or if you have an improvement in the first place, and then a new deterioration occurs, these are, of course, signals for the adsorber being saturated or being no longer able to work at the highest removal capacity anymore. In theory or in principle, you can, of course, also measure a substance at the inlet of the adsorber and at the outlet of the adsorber. And initially, you should see a difference here. And if this difference is then lost over time, so it requires serial measurements, of course, then this is another indicator for the cartridge being saturated. But probably more feasible for clinical practice is really to look at the clinical picture. And if you have more of a plateau in the clinical stabilization, or even an initial or again a deterioration, then this should be interpreted as a potential saturation and should encourage you to change the adsorber even before the 24 hours are reached. After 24 hours, you should exchange the adsorber in any way, and whether to continue or not is dependent again on the clinical picture, mainly whether you have achieved a sufficient level of clinical stability. Yes, then you could allow yourself to not continue CytoSorb therapy. If not, then we advise you to continue with another cartridge. Some even also take the IL-6 levels to go down to the value where they started from, or let's say below 500. But the majority of the clinicians we know rather take the degree of hemodynamic stabilization. And I showed you in the flow chart, so shock reversal, norepinephrine doses below 0.05 microgram per kilogram per minute might be a kind of threshold for you to then stop the therapy. I hope this is sufficient, but it's of course a very relevant question, and we are working further on to trying to support this even better. So another question from Faranas Fahalian, I hopefully pronounced it in the right way, sorry if not. Is it possible to use CytoSorb filter that program to absorb special inflammatory mediators while many confrontations of the German body may be cellular and not? I'm not sure whether I get the full question, but of course you can only remove from the CytoSorb with CytoSorb from the blood compartment. Yeah, if you removed it from the blood compartment, and this is also the so-called cytokinetic theory, how blood purification could work in principle, you have restored the gradient from the blood to the focus, so to the infected tissue, which should enable the immune system to refocus on the initial problem. You might also have, and this is sometimes maybe the explanation why sometimes the levels in the blood didn't change that much after blood purification therapy. You might also have a bit of a redistribution of tissue inflammatory mediators back to the blood compartment if you have purified the blood compartment. Germs, so pathogen, you cannot eliminate with the cytokine adsorber. They're simply too large. However, you can eliminate one or the other bacterial toxins. So the pathogen-associated molecular pathogens, which also play a very important role in this setting as a trigger substance. Some of them can be removed. However, I want to be frank again, endotoxins, so LPS, lipopolysaccharide, cannot be removed by the CytoSorb adsorber. But in principle, it can only reach what is in the blood compartment. What's about antifungal treatment and CytoSorb? Among, as I said, these investigations in regard to, the question was, what about antifungal treatments and CytoSorb, again from Gabriel Preda, also a very relevant question. Our investigations in regard to impact of CytoSorb on medications of importance is ongoing. We know from this study I showed you with the 17 anti-infectives that fluconazole is also a substance which appeared to have, or CytoSorb appeared to have a certain effect on the substance. So we cannot exclude that there is a certain removal happening. However, we unfortunately are not there yet to give you any compensatory dose. In principle, we always recommend to be at the upper range of the normal dosing levels, of course, and always to use therapeutic drug monitoring. If you are in doubt, sometimes a repetitive dose after 2 to 3 hours or a shortening of the dosing intervals can, of course, also increase your safety margin for vancomycin. As I said, we learned that the 500 milligram, it seems to be a good compensatory dose for fluconazole, one of the antifungals I know, or we know, where CytoSorb can have an impact. I can't mention any precise numbers, unfortunately, but our investigations is ongoing, and as soon as we have more information, of course, we will share this with you and provide it to you. So I hope this was sufficient as well. I can't see any further questions. So if everything is clear, I hope you enjoyed the webinar, and there will definitely more webinars upcoming from our side. There will be some in the field of liver and kidney, as I said, very promising fields of use. We will also have to learn a lot, but we also have quite some nice data already, and this will probably happening in the coming month, and also one or the other nice publication will be shared with you in the form of a webinar, but we'll let you know once we have precise dates for this. So Guillermo Pinson Velasquez, again, I'm sorry for my pronunciation. Also, I don't speak any Spanish. I really apologize. Good day, excellent talk. Thank you very much. Guidelines for rhabdomyolysis, the hemoperfusion with CytoSorb would be the first option. We are, of course, not there with the guidelines. And in principle, for rhabdomyolysis, there is an approach to use it before the onset of acute kidney injury, with the idea of preventing even acute kidney injury. There's a nice case report that have tried this approach. They have been successful, knowing that a case report never proves anything, so it can also be not seen as an evidence, but at least the authors tried this approach by using, in a young patient, CytoSorb really at a very early stage, and the patient didn't develop in the further course any acute kidney injury, and also had quite a nice reduction of myoglobin levels. However, we also know from other data to come that even if dialysis is already there, the combination with CytoSorb might be able to reduce the length of the dialysis need in comparison to those who just had dialysis in rhabdomyolysis. So This is something to be hopefully published in the nearer future, so we will learn more about this, and then of course there might be a better base to discuss about guidelines one way or the other. It's not there yet in any way, but it's a very interesting, very promising field of use. And as I said, we might also have a webinar on this next to liver failure in one of the upcoming webinars in the coming month. But thank you also for this question. And if there's not any further question, I once more thank you for your time. Have a nice day, nice afternoon, nice evening, night from wherever you're joining. I thank my colleague Teresa for supporting me with the questions, and I wish you all a nice day and hope to see you soon. Thanks for joining.